Well, welcome back. We're going to switch our gaze now from making accurate diagnoses to understanding how good physicians with good diagnostic skills sometimes still make bad diagnoses. Diagnostic error is really the elephant in the room in the patient safety movement. Almost all interventions designed to enhance safety to date have focused on ensuring that the right patient gets the right diagnostic test or the right prescribed treatment. And they assume that the diagnosis that prompted that therapeutic decision was correct. And that's why they focus on things like barcoding, which help identify the correct patient, and checklists to make sure that once you know the patient has sepsis, you do everything indicated for sepsis. But we still haven't been able to figure out a good and systematic way to minimize or identify diagnostic error when it occurs. Now, when we think about what it takes to make a correct diagnosis using our differential diagnosis and test interpretation that we've been working on, we can identify several steps. And some of these steps involve knowledge and some involve skill. And these are relevant to some of the patients we've been talking about. So first off, when you see a patient, you have to establish a differential diagnosis. That requires knowledge and judgment, as we've been talking about. Secondly, you have to choose the correct diagnostic test for the particular disease that you're considering. Again, a knowledge-based decision. Then you have to be able to perform the test correctly. And this isn't always the case. For instance, some tests, we just order the test and it goes to the lab and they do the test. But other tests, like the Epley maneuver for benign positional vertigo, the physician themselves has to do the test. And so we have to make sure that you have the skill to do the test correctly. And then finally, once you get test results, you have to understand what it means. And we've been talking about that in terms of knowing how to estimate what the pretest probability is, and then move from the pretest probability with the test result to a post-test probability. Finally, all of these steps, every single one of them, can be impacted not only by deficiencies in knowledge or skill, but by the presence of cognitive biases. And we're going to spend a lot of time today talking about those. So just from a high-level view, there are a couple of broad categories of diagnostic error. The first is what I would call clinical input error. And this occurs when the wrong data is collected from the patient. So it could be due to a lack of clinical encounter skills. So for instance, somebody could ask the wrong history questions or incorrectly interpret the physical exam. In the case that we've been working on, if the initial resident didn't pick up the fact that the patient had a weak arm and thus misdiagnosed the patient as just having isolated vertigo rather than vertigo and paralysis of an arm, this would be an input error. The second category of errors is what I call clinical analysis errors. In that situation, we have all of the right data. We took an absolutely perfect history and an absolutely perfect physical exam and interpreted it correctly, but we didn't put things together well. And the causes of these clinical analysis errors could either be a lack of knowledge on the part of the physician. For instance, maybe the patient has a disease that you don't know about, or whose disease characteristics you've mistaken. Or, as I mentioned on the last slide, cognitive biases, which are mental models that trip us up, even if we do have the right knowledge. We're going to begin by understanding how experts view thinking and error. And this has actually been a very big topic of cognitive neuroscience over the past 2 decades. What I want you to take home from this talk is that we are, no matter how deliberate and how definitive and careful we are in our work on a daily basis, we're essentially creatures of habit. And it's only when habits fail that we resort to more conscious forms of thinking. Now, a recent popular book, Thinking Fast and Slow by Daniel Kahneman, talked about the contrast between System 1 thinking, which is fast, intuitive, and effective, and System 2 thinking, which is slow, deliberate, and taxing. And we find, in fact, that we spend much of our day in System 1 thinking, where we're instinctively making decisions about the data that's put in front of us. And in fact, we need to do so in order to navigate the very busy world that we live in, where we're constantly being bombarded by data and questions and decisions we have to make. But sometimes when things go awry, we have to slow down and engage in what's known as System 2 thinking. Now, if you think back to our original conversation, Module 2, about how experts make decisions, there's some parallel thinking here. And that is, experts tend to focus on a strategy of problem solving known as pattern recognition. That is, in essence, a physician's manifestation of System 1 thinking. It's fast, it's intuitive, and it's effective and generally accurate. At the other end of the spectrum, very slow, deliberate, and taxing is the hypothesis testing. And somewhere in the middle is our friend, forward thinking. Now, James Reason, who's written extensively about human error, is a British neuroscientist, and he calls System 1 thinking and processing skill-based activity. Now, skill-based activity, as we mentioned, is intuitive, automatic, and largely subconscious. And it's used for anything that we do frequently and regularly. We will develop an ability to do it in skill-based activity or in System 1 thinking. Think about yourself driving a car. Many of us have had the experience of getting into our car at the end of the day from work, getting home about 45 minutes later, and having no understanding of what happened in that 45 minutes. It was as if we were driving unconsciously. Well, we were certainly conscious. It's just we were on automatic pilot. And in an environment where we're used to driving, that's going to work very well. And we'll contrast that in a minute to the first time you drove a car, because I suspect the two activities don't really resemble each other very much at all, the novice driving a car and the experts driving a car. Now, it turns out, just as we've talked about in the way experts store information in the form of illness scripts for medical decision-making, that System 1 thinking and skill-based activity relies on this concept known as a schema. And a schema is a set of diagnostic and therapeutic information in the medical environment that's packaged together as pre-programmed connection between thought and action. So some people have called that stored patterns of pre-programmed instruction. You have that in your car driving, and once you consciously activate the decision to drive a car, the performance flows pretty automatically. But importantly, when you're working in System 1, built into those schema are these periodic monitoring checks at critical periods where your brain knows you have to actually, for some instant, stop and pay attention to what's going on. It's really remarkable how this happens, but once you know about this idea of System 1 and skill-based activity thinking, you'll be able to recognize it in yourself and in others. So pay attention as you look around you this week. Now, as I said, schema will develop for anything you do very frequently, and they tend to be context and individual specific. So some people do a lot of things the same on a daily basis, and some things do a more wider variety of things. But for example, there are procedural schemas. So a surgical chief resident who does literally dozens of central lines every month is generally operating under schematic control when they're putting in a central line. They can do it effortlessly, almost without thinking, and work through all of the steps of that checklist that might be relevant. So is the same as we see a CT surgeon who's doing a CABG or a coronary artery bypass grafting, for those of you who are not familiar with that mnemonic. But importantly, a new intern inserting a central line is not going to be under schematic control or System 1 control. That's what I mean about situation being context and individual specific. And if, in fact, the chief resident who learned to do central lines only learns to do them at one site, for instance, the internal jugular line, when you ask him to put in a central line in a different site, for instance, in the subclavian area, they may not function under schematic control for that specific context. Now, it doesn't have to be procedures. Schematic control exists for cognitive decision-making and action as well. So an internist who spends much of their day diagnosing high blood pressure and treating high blood pressure actually largely does that effortlessly without a lot of conscious thought until the blood pressure runs into trouble. And similarly, a rheumatologist diagnosing gout might similarly be operating under schematic control. Now, it's important to understand that a schema, which is that pre-programmed set of instructions, occurs, as I said, for almost any activity you do on a regular basis and you do until you get good at it. They can be very, very complex, as the surgeon doing a bypass operation suggests. And they're really limited only by your own brain capacity. People who have expertise in a wide variety of fields have schema in a wide variety of fields as well. Now, rule-based activity is midway between System 1 and System 2. It's used for situations that are familiar to us, but not exactly everyday occurrences. Or they're sometimes used when you thought it was a familiar situation and launched your approach to the situation with a schema, but then instead needed to try something different because things weren't working out the way you had hoped. Rule-based activity relies on stored rules for generic situations, and they're much less specific than the skill-based decisions. Some people refer to this as the one-size-fits-most type of problem solving. So you can recognize when someone's in rule-based activity because they work in algorithms. They work in these sort of if-then statements. Sounds a lot like the forward thinking we were talking about a few weeks ago, doesn't it? So for example, if the car doesn't start, then check the gas gauge. Now remember, we said car driving for most of us who've been driving all our lives is under schematic control. This is an example where you choose a schema, you go out to start your car. If it doesn't start, you have to switch into another form of problem solving, something that's familiar but not common, like checking to see if the battery is dead or if the gas gauge shows no gas. The same can happen in very complex situations. An internist diagnosing essential hypertension and treating essential hypertension will be functioning under schematic control until it's apparent that the schema for a particular patient isn't working. And then they use these if-then rule statements. So if the blood pressure doesn't respond to 3 drugs, then maybe it's not essential hypertension. You should search for a secondary cause. Or if instead I'm an infectious disease expert and I think the patient's on the right antibiotics because of my diagnosis, then I'd say if the patient remains febrile despite those antibiotics, then I should look for an abscess. So again, rules-based activity, algorithmic thinking, if-then statements, one size fits most, not one size fits all. Now, the most deliberate form of problem solving we mentioned in the differential diagnosis world is hypothesis testing, where you have to work systematically through long lines of differential diagnosis in order to get to the right diagnosis. And similarly, knowledge-based activity is as conscious, as deliberate, as rational as that hypothesis testing. And it's typically used in novel situations or ultimate problem-solving failures. So an ultimate problem-solving failure, for instance, the internist managing hypertension, they used their generic schema. They didn't work, so they tried the if-then approach to rule-based activity. And if the patient still has high blood pressure, they might sort of reflect back on a more maybe physiologic approach to this patient's blood pressure problem, because the typical forms of problem solving that have stood them well for all other patients aren't working. System 2, or knowledge-based activity, relies upon this conscious synthetic problem solving, and it requires people to simultaneously access, process, and apply stored knowledge to the situation at hand. So while you're taking information from the patient, you're thinking about it, and you're trying to actively pull things out of your brain in order to help solve this very complex or difficult problem. And it requires really constant attention and frequent rules checks. And because this constant attention is so important to carrying out this type of activity, this form of problem solving, system 2 or knowledge-based activity, is very challenging, intellectually taxing and really unsustainable for a long period of time. You just simply can't keep your attention as focused as you need to. So let's give some examples of knowledge-based activity. And you generally know you're dealing with knowledge-based activity because when you see somebody engaging in this type of problem solving or procedural activity, they're not very fluid in their activities. They're very jerky, and it's almost as if each step requires them to stop and think, even for a microsecond, before they proceed down the right path. Recall your first driving experience. Now we know you can get in the car and almost subconsciously get home, but that first driving experience, I suspect, was pretty jerky as you were driving around the neighborhood trying to remember, when do I put my foot on the brake? When do I put it on the accelerator? When do I shift? How about the turn signals? What if it starts to rain? I suspect a lot of you can relate to that. The same is true in medicine. The first central line takes hours because you have to keep going back to the checklist. Even the first history and physical, we see medical students, of course, struggling through that and spending hours looking through a list and going back and forth to the patient with questions they've forgotten. And And the initial diagnostic quest for a new patient for novices often is an example of knowledge-based activity, and they may revert to that old hypothesis testing we talked about a few weeks ago. But even experts in a field will resort to knowledge-based activity or hypothesis testing when they're faced with a problem that just isn't able to be solved in more automatic activities like skill-based or rule-based activities. So the patient who doesn't get well. So if there's a patient I'm working with and I really thought I knew what was going on, but in fact they're not getting better with the treatment that's appropriate for that diagnosis, I may actually spend a little bit more time thinking what might be going wrong here in order to make a better diagnosis. What this slide reflects is the differences in the way experts, intermediates, and novices approach different problem-solving strategies in the problems that they tackle on a daily basis. Of course, this course is about clinical problem-solving, but these concepts are very relevant to any type of problem-solving that you'll engage in your daily life. And what we see from the literature is that experts spend a lot more time in System 1 thinking, and novices spend a lot more time in System 2 thinking. In fact, some people define expertise by the proportion of time you spend on your daily workday in System 1 type activities. Now, many people make the mistake of saying that System 1, which is intuitive, fast-paced, snap judgments that are subconscious, must be intellectual laziness. And what we all really want to be working in is in System 2, because that's much more methodical and thoughtful. But in fact, remember what I said about System 2 work. System 2 work is so intellectually taxing that it's difficult to sustain it for a very long period of time. And so people tend to give in before the best solution is arrived at. And when you look at the percent of errors, you see that the error rate is much higher in System 2 thinking than it is in System 1 thinking. Doesn't mean that System 1 thinking has no errors, and what we'll see in a minute is the types of errors that occur vary depending on whether you're working in skill-based activity, rule-based activity, or knowledge-based activity. So, let's stop for a quiz. Experts, or people who are considered to be experts, number 1, use more System 1 thinking and make fewer errors. Number 2, use more System 2 thinking and make fewer errors. Or number 3, use more System 2 thinking and make more errors. Got the answer? Sure you did. It's number 1. Use more System 1 thinking and make fewer errors. That's the characteristic of an expert. Now, as we alluded to in that last slide, what's really interesting about work on cognitive errors is that the type of error you make depends on the type of thinking or activity you're engaged in at the time the error occurs. When you're working in System 1 or skill-based activity, the types of errors you make are known as slips. And these are execution errors. You plan to do something correctly, you planned a specific outcome, and yet there was a disconnect between what you intended and what actually happened. In contrast, System 2, and we're going to lump together here those rule-based, the algorithmic if-then, and knowledge-based activity. When an error occurs then, it's known as a mistake. And these are really planning errors. You chose the wrong good enough rule, and you didn't actually pursue the right steps in your knowledge-based activity. These are normal and anticipatable cognitive errors that happen even to the very best of physicians. And I want to contrast them very deliberately with what I'll call violations, which are errors that result from a disregard for appropriate established protocols. These are not cognitive errors. These are errors related to professionalism. So let's look at System 1 errors for a few minutes. System 1 errors are skill-based activity errors. Remember, this is the intuitive, fast-paced, almost subconscious decision-making and action. Occur when the right solution was chosen, but the outcome was not what was intended. And this tends to occur when there's an imbalance between those internal monitoring checks and the automatic activity. Remember I said the schema that drives System 1 behavior, those pre-programmed packets of information and instruction, have built-in monitoring checks. And if something happens to impact those monitoring checks, that's when skill-based slips will occur. So these are heavily impacted by stress, fatigue, boredom, multitasking, and workload. Multitasking, like paying attention to your phone when you're supposed to be actually paying attention to a monitor. So here's a couple of types, categories of System 1 errors, and the cognitive psychologists love categories, and when you read about these issues, you'll find a lot more of them, but I want to give you a couple of very common ones. The first is a distraction error, and this is where the periodic checks that you need to engage in are decreased. We'll give an example on the next stage, but if somebody actually interrupts you while you're doing something, that may actually cause a distraction error. It seems pretty obvious. A capture error occurs when the need for monitoring increases and you didn't monitor it. I'm going to use another car analogy for this. So if in fact you normally drive home and you leave your work and go directly home, but then today you're told you need to stop and pick up the child at a friend's house before you get home, unless you pay attention very deliberately to that turnoff where your child is, you're going to arrive home without the child. And I think it's happened to all of us. That's known as a capture error because we needed to change our monitoring pattern for the usual schema. And if we didn't deliberately do that, we end up with a mistake, with a slip. So clinical examples, how does this happen in the real world? Well, diagnostic input error or distraction error occurred. One example we used, a resident was reading a chest x-ray, and in the process of reading the chest x-ray was interrupted to deal with a patient who was having a contrast reaction in the next room. Came back to read that chest x-ray, but started off again at the wrong spot and therefore missed a pneumothorax. So that's known as a distraction error. Therapeutic errors occur as well. For instance, an anesthesiologist who's used to administering a series of drugs in a particular speed is now given a new antibiotic that requires a different infusion rate. And so in order for him to actually process that into his usual work in the operating room, he'll have to build a new schema to incorporate new monitoring steps, and if they don't, that will result in a capture error and a slip related to this particular infusion of antibiotics. Rule-based activity errors are planning errors. They're mistakes. And there's two broad categories of these. One is what some people have called the strong but wrong rule. So it's a good rule misapplied for the circumstance. You picked the wrong rule for the situation at hand. Or a bad rule, and that is a clinical rule that was anecdotally driven and should never have made it into your list of good rules. It just happened to work once, and you tended to extrapolate it to other situations. So here's an example from the clinical realm, and those of you who haven't quite gotten to this stage in your career, I'll tell you that esmolol is a powerful beta blocker that can be given through the vein for a high heart rate or a tachycardia. And there is a very strong rule that says if tachycardia is causing hypotension, you can give esmolol, stop the tachycardia, and the hypotension or low blood pressure will go away. Well, that works very well, but it's a strong but wrong rule if the tachycardia was not the cause of the low blood pressure, but in fact was the result of the low blood pressure. So an example of a rule that generally is not bad, but you have to use it in the right circumstance. So that is a mistake. Second rule-based example of a mistake, good, strong but wrong rules, give thrombolysis when angioplasty is unavailable. So in patients who have an acute coronary syndrome and can't get to a cardiac catheterization lab in the right amount of time, the strong rule is to give thrombolysis. That would be a wrong rule if you misdiagnosed the patient and they were not having an acute coronary syndrome, or perhaps were having something as bad as a dissecting aneurysm, in which case thrombolysis would be a really bad thing to give. So those are classic mistakes that we see in medicine. System 2 errors, or errors that occur in knowledge-based activities, again, mistakes, these are really interesting because they speak specifically to how we think and learn in a given environment and are quite relevant to this course. So knowledge-based activity errors occur when there are problems accessing the appropriate stored knowledge and applying new information. And that may occur if there are limitations in knowledge. As I said, if you haven't read enough and haven't stored it in a way that you can use that information in the clinical environment, you are not going to be able to make good diagnoses because you won't have the knowledge to recognize what's in front of you. But it also is a problem sometimes with short-term memory. And remember, as we started this course, we talked about the limits of short-term memory or working memory. Humans can really pay attention to about 7 plus or minus 2 elements at any given time. And so that's why we work so hard with our processing to get our problem lists down to 7 or fewer problems so that we can really pay attention without taxing our short-term memory and our working memory too strongly. Another type of problem we see that results in knowledge-based activity mistakes is the strong tendency to fit the problem into something we've seen before. And this refers to biases in long-term memory. Why do we do this? Why do we try and fit the problem into something we've seen before? It's largely because of the observation that it takes so much energy to be working through step by step by step, either a procedure or a diagnostic pathway. So we sort of give in and give up to a good enough fit. And that's why we run into difficulty if our major form of clinical problem solving is hypothesis testing. And there are biases that we can anticipate and perhaps begin to look out for that will tell us how those mistakes might be made. But unfortunately, biases and problems with short-term memory are the most difficult problems to analyze and recognize because they're largely hidden to us. When we make a slip error, we know it. For instance, if you're typing on a computer and you hit the wrong key, you almost instinctively know that you hit the wrong key. That's not the case with knowledge-based errors, and we'll talk about why in just 1 minute. So let's talk about some common cognitive biases. And there's a gentleman named Pat Crosscarry, who's an emergency medicine physician who's written dozens of articles about cognitive biases or mental models that trip people up and make diagnostic errors. The first bias is known as the availability heuristic. And we used heuristic a couple of weeks ago to refer to a rule of thumb when we were talking about our evidence-based medicine heuristic, using that likelihood ruler to estimate the impact of a test on a differential diagnosis. Do you remember that? Good. So the availability heuristic says that common things are common. And so the patient in front of me, I'm going to instinctively think, is more likely to have what the last patient had than something I've never heard of before. So the availability heuristic occurs all the time. If I saw a patient this week who had a bad pneumonia and it turned out it was due to resistant Klebsiella, and now I have a similarly sick patient, I'm going to guess that person has a Klebsiella pneumonia too, just on the top of my head without even going much farther. So that's known as the availability heuristic. Confirmation bias. Confirmation bias is everywhere in medicine and actually in our day-to-day work as well. And confirmation bias means that you give preferential attention to data that supports your initial hypothesis or decision rather than something that refutes your initial hypothesis or decision. Some people have referred to this as the travel bias. So if you get on the wrong train, going from Washington, D.C. to Minneapolis, Minnesota, and you look out the window and you see palm trees, confirmation bias says, you'll say something like, oh, isn't it nice that they planted palm trees between Washington, D.C. and Minneapolis, rather than saying, oh my gosh, I got on the wrong train. This happens all the time with medical diagnoses. A patient is given a diagnosis like pneumonia, and I decide they have pneumonia, begin to treat pneumonia, and pay attention to everything that supports my diagnosis and try and explain away things that don't support it. Now, all of you are thinking to yourselves, why would doctors ever do it? And the reason we do it is because you're hardwired to do this. It's a way that we help ourselves get through the day, but now that you know about it, you can begin to take some steps to protect against it. Third kind of bias you should know about, overconfidence bias. Some people call this eminence-based medicine as a play on words in contrast to evidence-based medicine. This is relying heavily on the opinion of experts. You're confident that someone before you had the right diagnosis. Now, when we applied these biases in the clinical world of our internal medicine residency program, we found that experts were quite variable, what people considered experts. It might just be the person who was a year ahead of you. So the intern thought the resident was the expert. The third-year medical student thought the fourth-year medical student was the expert. But it also could be the person who saw the patient first. So the primary team were experts in the eyes of the cross-cover team. So it's a common bias we have to avoid falling into from a trap perspective, because it prevents us from picking up our colleagues' mistakes, and that's something that we need to agree to do as a profession. Another interesting type of bias called premature closure, and that is stopping after one diagnosis and assuming the patient has one diagnosis when in fact they may have one or more diagnoses. There's an aphorism that the emergency medicine physicians commonly use, and that is the most commonly missed fracture in any given patient is the second one. So you see the first one and you stop looking. A couple of other interesting biases that affect us as a culture. One is fundamental attribution error, and that's the tendency to identify the patient as the cause of his or her illness. Patients sometimes help us with this. You know, they come in with mid-thoracic back pain and they say, oh, it must be because I lifted something wrong. When in fact, in your mind, you sort of know, you can't really strain your mid-back. Something else must be going on. And then there are commission and omission biases. Commission bias means there's a tendency towards action, like test ordering. And in medicine, we tend to punish errors of commission much less than errors of omission. Omission bias is something like a tendency towards inaction, like nihilism. And both of these may occur on an individual basis. So I've just given you a sample of some different types of biases. As I said, there's literally dozens of them, and I bet in your mind you can think of some other ones that might be affecting you on a daily basis. But I want to emphasize that biases are not always bad. These mental models help us get through the day, and the reason they're biases is that they've worked at some point in time for us. It's very difficult to identify your own biases, even when looking back at a case that didn't go well, because if I'm looking back at a case that I misdiagnosed, the same biases will be in place when I'm reanalyzing that case than as were when I analyzed it in the first place. And so if I really want to uncover some biases and correct some problems in my thinking, I need to get a friend to help analyze cases that didn't go well with me. And so that's one of the challenges I'm going to leave you with, is how do we learn to identify errors due to cognitive biases and learn from them? First, appoint a designated critic, or some people have said a designated cynic or designated curmudgeon. Somebody whose job it is to demand that you justify your diagnosis and treatment plan. This is a good thing to do in teams to avoid the concept of groupthink, where everybody is trying to be a member of the team and support people who are leading the team. And sometimes even if they have a little inkling that maybe they're going off on the wrong path, they'll swallow their uncertainty and just agree to go along with the rest of the team. We'd like to think that doesn't happen, but it does. And one way we as team leaders can prevent it from happening is to actually specifically articulate that you want John or Mary or Susan or Ahmed to be the designated critic today, and make sure that none of you fall into problems of confirmation bias, overconfidence bias, or availability heuristics. Cognitive discipline. Making yourself work through the systematic process to differential diagnosis that we've been engaging in the past several weeks is a great way to do this, even if you know instinctively that that patient has disease X. Now, should you do this with every single patient? Well, if you did that, you'd be constantly working in system 2, and you probably wouldn't be able to get through your day. But stopping every now and then to clear your head and make sure that you're not falling into a dysfunctional trap makes a lot of sense. And the final thing, and my colleague Matt Roosevelt is going to join us in a minute to talk about this, is what I would call reflection and analysis. Matt and his colleagues at San Francisco General Hospital have developed a strategy of working backwards on your forward thinking to identify where you might have deviated from and what data you overemphasized or underemphasized. So before I turn it over to Matt, who's currently a chief resident in internal medicine at San Francisco General, I want to leave you with one question. After listening to this lecture, can you tell me, do cognitive biases happen rarely and are easy to avoid if you're smart enough, or happen commonly and are difficult to avoid without conscious thought? And the answer, of course, I know you get this, number 2. They happen commonly and they're difficult to avoid without conscious thought. So let's think about ways to structure our conscious thought in the next section.